Welcome to the lecture on the retroperitoneal organs and the blood supply of the abdomen. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. In this second part of the retroperitoneal lecture, I will describe the pertinent structures of the abdominal aorta, the inferior vena cava, and the portal system. I will present brief examples of what happens when these vessels fail to function properly. Let's begin. The last topic to discuss in the retroperitoneal space is the blood supply. The blood supply to the abdomen, as you must have gathered, is somewhat complicated, but it can be explained in terms of its development in utero. The drawing demonstrates a schematic of the abdominal aorta, giving rise to the three unpaired vessels that supply the abdominal organs. These unpaired arteries are the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. The celiac artery provides arterial blood to the foregut. The superior mesenteric artery provides arterial blood to the midgut, and the inferior mesenteric artery supplies the hindgut. As briefly described previously, the foregut extends from the distal esophagus to the duodenum. The midgut encompasses the distal duodenum to approximately 2/3 of the way of the transverse colon, and the hindgut is indicated from the transverse colon to the proximal 1/3 of the rectum. Also, remember how the abdominal artery enters the abdominal cavity. It runs just behind the diaphragm at the T12 level. Let's now discuss the arteries arising from the abdominal aorta. On the left panel, I made a drawing of the abdominal aorta, and on the right, an actual dissection of the aorta is shown. This dissection was made by Dr. Brana Vidic in the late 1970s. As a review, we again list the unpaired visceral arteries, the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. Next, I label the paired visceral arteries, the suprarenal, the renal, and the gonadal arteries. And last, I show you the paired parietal arteries, the inferior phrenic arteries, the subcostal arteries, the four pairs of lumbar arteries, and the termination of the abdominal aorta into the two common iliac arteries. One remaining artery to indicate is the median sacral artery. Also, note that the paired parietal arteries that arise from the dorsum of the abdominal aorta are not shown in the dissection. They are almost impossible to demonstrate from this view. If you wish to know an issue of clinical significance related to abdominal aorta, it is that aortic aneurysms, now shown on the dissection, can be deadly. Smoking and high blood pressure are the most common causes of an abdominal aortic aneurysm. A ruptured abdominal aortic aneurysm is a vascular surgical emergency in which 50% of patients die before reaching the hospital and may carry an overall mortality rate of 80 to 90%. Having discussed the arterial supply, it is now important to mention the venous return. I now label the inferior vena cava, with which you are familiar with, and note that it is located to the right of the abdominal aorta. In general, it is safe to assume, when dissecting, that the corresponding veins will be to the right of the named arteries. In reality, as I've alluded to briefly in previous lectures, there are two venous return systems in the abdomen. One, the IVC, just demonstrated, and two, the portal system of veins that drain the gastrointestinal system. A portal circulation is one that starts and ends at a capillary bed. The portal circulation of the abdomen starts at capillary beds in the abdominal organs, forms larger vessels that then end as capillary beds within the liver. The portal circulation of the liver then drains to the IVC by way of hepatic veins. The hepatic veins are often forgotten in a dissection when looking at an isolated liver. Look at the isolated liver on the right panel and observe the IVC posterior to the liver and the openings of the two hepatic veins that drain to the IVC. Let me now list the veins that drain to the IVC, and to be able to show the majority of the veins, I need a drawing. Oftentimes, different angles of dissections are required to demonstrate the veins that drain into the IVC. From superior to inferior, I indicate the inferior phrenic, the hepatic, the renal, the lumbar, and the common iliac veins. All these veins are bilateral, but their drainage into the IVC can vary some. Additional veins include the suprarenal veins and the gonadal veins. However, their drainage into the IVC is somewhat different than the other veins. Note that the right gonadal vein drains directly into the IVC, whereas the left gonadal vein drains into the left renal vein. As explained earlier, this distinct drainage pattern can lead to the nutcracker syndrome, where the left gonadal vein is more susceptible to blockage, but not the right one. The same situation arises for the right versus the left suprarenal veins. Right suprarenal drains directly to the IVC, left drains to the left renal vein. In principle, it too can be backed up, but not clear what results occur when the left suprarenal vein is backed up. But in addition to the IVC, I need to describe the formation of the portal circulation and also explain what can go wrong to these vessels in response to liver disease. Shown on the left panel is a drawing of an anterior view of the venous return from the abdominal organs that gives rise to the portal vein. On the right, the portal vein is shown in an isolated set of organs, but this is the posterior view. It is much easier to demonstrate the portal circulation in a posterior view in isolated organs. The portal vein is formed from the joining together of the superior mesenteric vein, the splenic vein, and the inferior mesenteric vein. Not shown in the dissection is another important contributor to the portal circulation, the esophageal plexus of veins that drains the lower third of the esophagus. Ultimately, the portal vein will drain to the hepatic veins. Now, the issue becomes, what happens when liver disease ensues, for example, cirrhosis of the liver, and portal drainage to the hepatic veins is impaired? If the situation persists, the venous return goes from abdominal organs to liver, to now going from liver to abdominal organs. However, what is happening here is that the venous return within the portal vein is looking for a path to the systemic circulation via the inferior vena cava, its original path to the hepatic veins, blocked in part by the cirrhotic liver. The impaired drainage of the portal circulation leads to a condition known as portal hypertension and is characterized by the appearance of caput medusa, a disease named after the mythical creature whose hair was turned into snakes. Cutting off one of the snakes led to the onset of more snakes appearing in her head. On the left, I show an image of a tile floor of the mythical Medusa that I took years ago from a Roman site in Spain. As to why it is called caput medusa, look at the image of a patient shown on the right. The abdomen of the patient appears to be filled with worms. These engorgements are nothing more than venous return blocked due to the liver disease. Let me explain how these venous engorgements occur. When blockage of venous return through the liver occurs, three things will happen to the portal veins. They will engorge, dilate, and varicose. Venous return in these will undergo a retrograde flow in its direction and looks for venous anastomosis with veins that drain into the caval system of veins. These anastomosis occur at four locations. 1. Between the esophageal branches of the left gastric vein and the esophageal veins of the azygos vein. Engorgements of these veins are known as varicoceles and can pose a significant clinical event. Patients have been known to bleed out when these rupture if not treated, generally by cauterization. Once varicoceles develop, life expectancies diminish in these patients. 2. Between the superficial rectal branch of the inferior mesenteric veins and the inferior and middle rectal veins, branches of the internal iliac. These will appear as hemorrhoids and will be painless. I repeat, painless. Painful hemorrhoids occur in the anus. These engorgements instead are of veins arising from the hindgut. Consequently, they have different receptors. Late pregnant women sometimes also exhibit painless hemorrhoids, but these go away or tend to go away after parturition. 3. Between superficial veins of the anterior abdominal wall and the paraumbilical veins draining into the portal vein. These are the engorgements that produce the caput medusa. While the portal hypertension can be managed in some patients, the caput medusa tends to be permanent. And 4. Between the retroperitoneal veins draining the retroperitoneal structures and the tributaries of the portal vein draining the same structures. These are difficult to discern because of their location. In the past, a common test to determine the extent of varicoceles was to ask patients to drink barium and image the esophagus. In a normal upper GI image, the barium form a uniform radiopaque column as shown on the image on the left. In contrast, if varices or varicoceles were present, image on the right, a honeycomb pattern was observed after a barium meal. Today, an endoscopic procedure is done in which a thin catheter is introduced into the esophagus and imaging is performed. The presence of varices in the esophagus are easy to detect and pathognomonic for portal hypertension. Treatment of portal hypertension can be performed using two approaches, but only in cases where patients are willing to engage in lifestyle changes. The treatment is not curative, but can manage the disease. First, in a portal caval shunt, the procedure requires a major surgical intervention. A shunt is placed between the IVC and the portal vein as shown in the image. Think of how the portal vein and IVC must be reached to then manually place a shunt between the two. An alternative, less invasive procedure is the transjugular intrahepatic portosystemic shunt, or TIPS, in which a catheter is inserted into the jugular and driven until reaching the portal vein. Connecting the caval and portal systems leads to increased blood flow and the blockage caused by the cirrhotic liver reverse to some extent. Of course, this does not result in a panacea. There is a biological reason that portal vein must first filter through the liver, and these procedures minimize this flow. Generally, the TIPS procedure is attempted first, and the portal caval shunt will be performed if the TIPS does not alleviate the portal hypertension. The last system to discuss in the retroperitoneal space is the lymphatic system. Remember, if you know the arteries, you know the lymphatic system. It returns to systemic circulation in a retrograde direction to the arteries. Hence, in the abdomen, there will be pre-aortic lymph drainage to nodes that are following the unpaired arteries arising from the abdomen, and para-aortic lymph nodes corresponding to arteries that arise from the lateral borders of the abdominal aorta. This now concludes this lecture on the retroperitoneal organs and its vasculature.